Hello, good day. I'd like to thank you for the opportunity to share a bit about renal pharmacology. Now, renal pharmacology for me actually was very difficult. In fact, when I was a med student, I took removals for pharma. But I would like to share with you what has helped me through the years to make it easy and to make it make sense to me as a practicing nephrologist. So these are my disclosures. At today, at the end of the hopefully 20-minute interactive lecture, so I hope that I'll be getting some interaction from you. I hope to be able to discuss and share the following about renal drugs, their mode of action, adverse drug reactions, contraindications, and precautions. But we'll be focusing, especially today, on the mode of action because I think this is the most important. So change is most definitely a part of life, and we're undergoing a lot of climate change in the Philippines and also a lot of pending leadership change. So for today, I hope that we'll be interacting in terms of our politics and in terms of this lecture. So in order to just to have a trial question, I'd like you to type your answer in the chat box so that we can check if it's working. So who are you thinking of voting? Sige nga, can you please type in the chat box? Okay, interesting. Interesting. So this is how we're going to proceed interspersed in the lecture. I'm just going to be asking some questions and you can type your responses in the chat box. So why is it important to discuss renal pharmacology, or why did I get this lecture? Because actually chronic kidney disease as a nephrologist has been on the rise these recent years. I'm sure you have had relatives. Can you type in the chat box if you have yes, if you have relatives or somebody you know that has dialysis or kidney disease, and no if you have none? Okay. So chronic kidney disease is quite a silent killer and it affects 10% of our population. All people can be affected of all ages, but it affects more people as we grow older. And hypertension and diabetes are the most common. And in this 2016 data, three-fourths of the patients on dialysis have kidney disease because of diabetes and hypertension. As such, the pharmacology also of diabetes and hypertension, the medicines that we learned about it are important because you'll be encountering this in your family and in daily life as we go along. Now, in order for us to have a clear understanding of renal pharmacology, it's important for us to recall renal physiology because what we remember in pharma is that we give medicines when something is no longer broken, no longer working. Pharmacology is a way to fix what is already broken. So we need to review a bit on renal physiology. So as a review, just remember back to your physio days about the kidney. So what are the functions of the kidney that you know? Please type in the chat box. Okay. So the normal kidney function is to keep homeostasis in the body by excreting those that we don't need. Mainly, it functions in filtration, so excreting solutes that we don't need, water balance, so in order for us to be not edematous but euvolemic, hemoglobin balance, in order for us to prevent anemia, acid-base balance, so this is the bicarb, carbon dioxide, and also it has functions in bone health. Now, the kidney, when it is well, looks like this, but when it becomes destroyed, chronic kidney disease, it becomes smaller, and the functional unit of the kidney is no longer working. Then we have what we call chronic kidney disease, which is the eighth leading cause of death. Now, if we recall, the function of the kidney mainly is an excretory organ. So our body would be doing its metabolism, using food in order for us to build muscles, function well. But of course, there are waste products. So like anything, there would be waste products. So these waste products will travel in our blood through the renal artery and go into our kidney, which would act to filter it out and differentiate those substances that our body can still reuse. So these substances would exit through the renal vein. This is the filtered blood. And then the substances that we don't need anymore would exit through the ureter into the bladder to be voided at a convenient time. Now, if the kidney isn't working well, there can be a problem regarding what is returned into the body and what is excreted. So the kidney is responsible for for releasing the electrolytes, the poisons, the water, the creatinine, and the other solutes we don't need anymore. And this is done by a functional cell of the kidney, which we will magnify and zero in, that we call the nephron. So if you recall, this is the nephron. Now think back to your anatomy and physiology days. Can you remember certain parts of the nephron? Type in your chat box, what are the parts of the nephron that you remember? Okay. So these are the different parts of the nephron. If I lead you through the physiology of it, we have that our blood would be entering through what we call the afferent or approaching arteriole, and then the filtering would happen through the glomerulus, and then those substances that we don't need would be exiting through the efferent arteriole. Now, when this filtration takes place from the blood, the substances that we don't need would initially go out through the urine, through into the Bowman space and travel through this long part which we call our tubule. Now, the tubules are divided into four parts. We have the proximal convoluted tubule, which is a thick part. This reabsorbs most of the substances and the osmolytes like glucose, urea, and uric acid, among others, and also amino acids. Now, after that, we have our loop of Henle, which is divided into two parts. We have our thin descending limb and the thick ascending limb. Now, here in the thick ascending limb, what happens is that we also have the water that is balanced, and then eventually we would have that the urine would travel through the distal convoluted tubule and eventually through the cortical collecting duct. Now, the urine would be regulated through this time so that um, these tubular parts act like scavengers. They try to gather what they need the most in order for our body to preserve what we need and release what we don't need anymore. Now, since these are the functions of the kidney, if these aren't working anymore in chronic kidney disease, we have appropriate drugs or appropriate interventions that can act. So for filtering or taking out of the solute, actually, there's no drug that I can think of that we drink that can improve the filtering capacity of the kidney. So what we have is a kidney outside the body, which we call dialysis. For the water and salt balance, these are the different classes of drugs that we have. So we have our diuretics, the aquaretics, and then in cardiology, we already discussed our ACE inhibitors and our angiotensin receptor blockers. So these usually balance the water and the salt, and the aquaretics balance the water. Now, for hemoglobin, in order for our blood to become red, we have what we call our erythropoietin, which is secreted also by the tubular cells. So you'll be discussing this likely in the hemo module. And then for the acid base, our kidney is responsible for producing sodium bicarbonate. So if our kidney is not able to produce enough of this for our body, usually what the patients do is they just take this in order to replace the sodium bicarbonate that we require. And then, of course, the kidney is also responsible for bone health. It has an active part in calcium metabolism, phosphorus metabolism, vitamin D. So these are the different medications that we have. If we have low calcium, we can just replace them. If we have low vitamin D, we can replace. And we also have what we call our calcium mimetics. But I believe these will be discussed further in the endocrine module. So for today's discussion, I'd like to focus on the water and salt balance, particularly on diuretic, because I think this is the most important for renal pharmacology module. Now, please type in the chat box, name the diuretics. What are the diuretics that you remember? Okay. So what is a diuretic? A diuretic is a medication that helps the body get rid of sodium and water. Contrary to our aquaretic, the aquaretic is one that just gets rid of water. The way the diuretic acts is that it gets rid of the sodium, and where the sodium goes, the water will follow. As such, it will increase the passage of urine, but sometimes because of its action of getting rid of sodium and water, other electrolytes would also want to follow. So para sila magbabarkada. Pag lumabas na yung sodium and potassium sa urine, the others would want to follow. And if they follow excessively, complications of too much diuretic intake would be electrolyte losses. Now, why do we give diuretics to patients? Usually, it's given to patients in order to decrease plasma volume. So the function of the kidney is to produce urine. So diuretics would do that if the kidney is not able to do that well, so that if we decrease the plasma volume, the inadvertent effect would be to decrease the blood pressure. Now, what does this imply? It means that the indications or the reasons that we give the diuretic would be for patients with increased plasma volume. So let's say patients who have congestive heart failure, chronic liver disease, or if you have chronic kidney disease and your patient is manas na manas, edematous, we would give our diuretic. It can also be given as a class of antihypertensive in order to decrease the blood pressure. So those are the indications. However, the adverse effects would be that if we give too much, the blood pressure can go too low, other than the electrolytes being lost. And as such, they are contraindicated in patients with electrolyte problems that are low and also contraindicated in hypotensive patients. Now, the classes of the diuretics are actually divided according to the segment of the tubule where they act on. So there are a lot of them, but for the purposes of today's discussion, I just like to focus on the osmotic diuretic, loop thiazide, and potassium sparing. The osmotic diuretic would act in the proximal tubule. The loop would act in the loop of Henle, as the name implies. Thiazide diuretics would act in the distal convoluted tubule, and the potassium sparing diuretic would act on the cortical collecting duct. So all of this would just happen in the order where the tubule evolves from the proximal to the collecting duct. Now, as such, we need to remember the action of each of the tubular parts, because the opposite will be the action of the diuretic. So let's review tubular physiology. Now, an important thing and the pitfall that I had when I was a med student is that I didn't remember these two concepts. So I would like to share them with you because I think it would make studying renal pharmacology very easy. Number one is to remember that where sodium goes, water follows. I always tell my patients, mag-asawa ang alat at ang tubig. It happens that when we take a lot of sodium, we become edematous. And this is also true in terms of renal pharma. So again, number one, most important concept, where sodium goes, water follows. So if there's a lot of sodium in the urinary space, we can expect that urine output will occur. The next is that for each of the tubule segments, there is a rate limiting transporter. So what does this mean? When I was a med student, when I would review the book for renal physiology, I would get very confused because there are so many transporters in each of the different tubular cells. So we encounter this picture a lot. We have the tubular cell, we have the luminal side or the urine side, and the basolateral side and the blood side. So what happens usually is that reabsorption would happen from the urine, going through the tubule and going into the blood. So what happens is that before when I study, I get very, very confused. Now, the important thing for us to remember is that usually there is just one rate limiting transporter. There's just one transporter that we need to remember in each of the segments. So you just zero in on that and try to ignore the rest. Not to say that it's important. Then when we zero in on these transporters, what we need to remember is that the other transporters will be affected by the lack of of the reabsorption that happens. So what happens is if this is affected, like in chemistry, right, the Krebs cycle, we have a rate limiting steps. So if this is affected, all these others would be affected as well. But for the purposes of pharma, what I would like to emphasize is that per segment of the tubule, you just remember that one important transporter. And that's the one that those are the ones that I would like to emphasize today. Okay, so again, let's go back to your renal tubule. So again, these are the parts. So again, now given these parts, I now like to zero in on the sodium reabsorption that happens. So big picture wise, what happens is that the glomerulus would reabsorb the substances, would filter the substances so that it would excrete the substance in the Bowman space. And then from here, the tubule is like the quality control. It would check the urine that will be passing through, and then what it can save as the urine goes here. Parang save lang sila ng save. The transporters are like garbage collectors. Parang they would save what they can back into the blood in order to excrete what we would want to excrete. So if, for example, the body has too much sodium, you wouldn't save a lot of it. But if, for example, the body has kulang na sodium, mag-absorb man si proximal, and then si loop, and then si collecting. So what would happen is that since the urine would be continuously changed as it goes along, we would expect that there would be less sodium reabsorbed in the collecting duct and a lot absorbed in the proximal tubule. Now, in the proximal tubule to begin with, through a passive action, usually sodium is reabsorbed, and 60 to 70% of the reabsorption happens in the proximal tubule through a passive process. Then we go to the loop of Henle, which is divided into the thin descending limb and the thick ascending limb. So in the thin descending limb, water is reabsorbed, but in the thick ascending limb, 25% of the sodium is reabsorbed through an active process, through the transporter that we call the sodium, potassium, 2Cl co-transporter. So these three electrolytes, magbabarkada sila. They pass through this door all at once. So if there's a problem with one, the reabsorption can take place. So again, in the thick ascending limb, 25% of the sodium is reabsorbed. Now in the distal tubule, we have this other sodium reabsorption area. Since naubos na nung proximal and nung thick ascending limb, yung sodium, only 5% of the sodium is reabsorbed here in the distal convoluted tubule. It happens through a transporter which we call the NaCl co-transporter, or the sodium chloride co-transporter. So what happens is it's like a doorway, magbabarkada din sila. So they both are reabsorbed, the sodium and the chloride together. So if one is not working, the other will not work as well. And then, so we have less sodium already, and then the urine will go down into the collecting duct, wherein we have what we call the sodium hydrogen exchanger, or the sodium potassium exchanger. Or the other books would call it NaKEX, sodium potassium exchanger. So what happens here is that if these two, they enter all at the same time, para magbabarkada silang papasok. Here, it's like a revolving door. The sodium would exit and the potassium would go in. So these are important to remember. 1, 2, 3, 4, 5, because these are the actions where the diuretics would take place. Now, the diuretics would like to prevent the reabsorption of the sodium, so they would often block these things in order for the sodium not to be reabsorbed, and where sodium goes, water will follow, it would exit the tubule. Now, let's zero in on them particularly for the mechanism of action. So first, you have the proximal convoluted tubule. So we are here. Okay, so if you remember from renal physiology, their proximal convoluted tubule is in charge of reabsorbing the different solutes, like maybe proteins, amino acids. We would have our urates, uric acid, and also the glucose. It happens by mainly a passive way. So since we have that, kaka-filter pa lang dito, mataas pa yung concentration, passively it would pass through the tubular cells and go back and be reabsorbed in the blood. Now, it's always important when studying the tubular cells, if we zero in on them, for us to take note of the structure. Now, the proximal tubules are acted on by what we call the osmotic diuretics. And what it does is it prevents the reabsorption of water. An example of this is mannitol. So we give this to patients who have stroke to prevent cerebral edema. Now, if we zero in, usually this is the picture that we will see. We have the cross section showing the tubular cells, and then we have the tubular or the lumen side. So we know that this is the apical side, and we have the blood side, and then this is the basolateral side of the cell. Now, what would happen is that there would be if substances are reabsorbed from the urine, they would pass through the tubular cell and go back into the blood. Now, in the blood, we would have a number of solutes, and we would have water. Now, what happens is that if we would want the water to exit through the proximal tubule, we can give an osmotic diuretic like mannitol. So mannitol would be excreted in the urine, and they act as osmolytes. Osmolytes or solutes. So they're like this. So the substances would be present, but we increase the amount of substances in the form of mannitol in the urine. So what's going to happen? Since there are a lot of substances, by osmosis, the water particles would go out, or wouldn't be reabsorbed. So remember, where there is a lot or higher area of higher concentration, there would be a greater amount of water as well. So what happens is that since the water will be stuck in the tubular lumen and won't enter, the flow of the urine would encourage the water to go out and diuresis would occur. Okay. How about in the loop of Henle? So in the loop of Henle, so we're here. The diuretic that we usually pay focus to is the area that we pay focus to is usually the thick ascending limb, because here in the thin descending limb, water goes out passively. In the thick ascending limb, furosemide is the drug of an example that we give. So this is a loop diuretic. So again, if we zero in, we would have the cross-section of our tubular cell. We have our tubular lumen or our urine side, and we have our blood sides where the reabsorption would occur. So we would have this transporter or this co-transporter, which we call the sodium 2 chloride potassium co-transporter, or other books would call it the NAK2CC transporter. Co-transporter. So again, what I mentioned, no, para sila magbabarkada, sabay-sabay silang papasok. So if one of they have separation anxiety, so if one doesn't work, the rest won't go back in. So in the normal nephron, what would happen is that if there's too much sodium here or the body would need more sodium, this transporter is activated. And then once it goes in, it goes out here through the sodium potassium ATPase pump in the basal side, and then goes back into the blood. Now, the action of furosemide would be, it would block this 2Cl. And as such, since magbabarkada nga sila, the transporter won't work for both the potassium and the sodium as well. So because the sodium chloride and the potassium aren't able to enter the cell, the other transporters that we didn't name anymore would also have difficulty in the reabsorption of calcium and magnesium. So these would also be inhibited. So again, since we have a lot of sodium in the tubular lumen, the water won't be able to follow in, and the water will be going out in the form of urine. Pulling with it all together, all these barcada that are not able to go back in. So if we give a lot of furosemide, what we expect to happen is that your patient will become dry because of the water outflow, and you would have also pan-hypoelectrolyte levels, or low for all of them. So usually the adverse event would be, would have low calcium, magnesium, sodium chloride, and potassium. So the important thing about diuretics, furosemide, is that it causes all electrolytes to go down if given excessively. This is an adverse effect of the drug. So na-absorb na sa proximal and then sa loop. So again, we'll go now here to the distal tubule. So here in the distal tubule, the drug example is hydrochlorothiazide. So everything, kaapelido niya thiazide, chlorothiazide, are in the same class, and this would act in the distal tubule. So if we zero in again, we have our tubular cells. So we have our tubular lumen, or in the urine space, and we have with our blood. Okay. So what would happen here is that the excess or the remaining sodium and then the chloride would be supposedly reabsorbed actively through what we call the NaCl co-transporter. So again, this is a door, magkabarkada yung sodium tsaka chloride. They would be going in through the apical side of the tubular cell and would later on exit here through the sodium potassium ATPase pump into the blood. Now, what the thiazide does is iniipit niya yung pinto, it acts and inhibits the sodium chloride co-transporter. So what happens then is that the sodium would remain outside in the urine side, won't be reabsorbed by the blood. Now, through a series of other interactions and paracellular transport, calcium and magnesium exit would also be inhibited. So this would be inhibited as well. And then because of the excess sodium present in the urine space, the flow would happen. So as an adverse event, opposite to our loop diuretic, what would happen is that if we take a lot of thiazides, we would have sodium and chloride losses, but we would have calcium hypocalciuria, or the calcium would not go out. So And then because of the percentage of the action of the loop versus the distal tubule, if we remember, the loop would excrete around 20% of the sodium and the distal tubule would excrete 5%. The hydrochlorothiazide or the thiazide or the distal tubule diuretics are usually weaker compared to the furosemide. Now, another special thing about the thiazide group is that it also has an action on your proximal tubule. It causes greater reabsorption of the uric acid in the proximal tubule. So an adverse effect of this would be increased serum uric acid, hyperuricemia, or clinically, if it affects the joints, it can cause gout. So again, an effect of hydrochlorothiazide is increased calcium levels or decreased calcium losses in the urine and gout. Okay. So next, you have the cortical collecting duct. Actually, for this class there are two, but I just like to focus in on the aldosterone receptor antagonist because that's what we commonly use in the Philippines. So here in the cortical collecting duct, this is a very special place. So what happens is that it reabsorbs sodium, potassium, and also it has reabsorbs water. So this is where we have what we call our diuretic action and also what we have our aquaretic action. So aquaretics are medications that cause just plain water without electrolytes to pass out, and they act in the cortical collecting duct. But for the purposes of today's discussion, I'll just be focusing on the intercalated cell of the cortical collecting duct, where we have the action of the potassium-sparing diuretic. And an example, most common example of this is spironolactone, which we use for BP, blood pressure control, and heart failure. So if we focus in detail here in the cortical collecting duct, again, we have our tubular cell, we have our tubular or our lumen urine side, and we have our blood side. So what normally happens is that if we have a lot, if we have lacking sodium in the body or if our body is intravascularly deplete, let's say we ran a marathon and we lost a lot of water, um, there is usually here normally in the intercalated cell, the transporters are not always there. So what would happen if we are intravascularly depleted? Let's say we ran a marathon and are dry, the aldosterone level in our body would be increased. So because of aldosterone, it would act on a receptor present in the cell and it would cause the production of this transporter. So this transporter is what we call the sodium potassium exchanger. So when we need more sodium or more fluid back in our blood, the aldosterone will create a lot of these. No? Magbibuild siya ng madaming pinto. So unlike the previous wherein they're magbabarkada na sama-sama, these are what we call exchangers. So you can imagine it's like a revolving door. When the sodium goes back into the blood, the potassium will go out. So what happens is that if we have, and then, so how will it work further? So what happens is that when the sodium goes back into the blood, and then the potassium goes out, there are channels in the apical side. So this would, oy, kulang ako ng sodium, kuha ka pa. So the sodium would go in from the urine into this. And these cycles would go on like a Ferris wheel. It would continue. However, if we have the aldosterone receptor antagonized, or if we have the receptor which is already occupied by spironolactone, the channel would not be present here. And as such, these two would not be able to bring in the sodium or bring out the potassium. So the aldosterone antagonist would affect these, and what would happen is that the sodium, instead of going in, would then stay here, and then the potassium would go in. So that's why we call it potassium-sparing diuretic. And then the urine would go out. So what is important for this one is that unlike the loop diuretic wherein the potassium is lost, for this one, if it works, if these are inhibited, potassium would stay inside the blood. So sometimes it causes, if we take it too much, we can have too much potassium in the blood or hyperkalemia. Okay. So that's it. Actually, those are the 4 things that I would really like you to focus on, mostly the mechanism of action. So for today, I hope that I was able to share with you the mode of action. So again, if you remember, the proximal is osmotic. The thick ascending limb is the loop, which acts on the NAK2Cl cotransporters. And then for the distal is the NaCl. And then for the cortical collecting, we have our aldosterone receptor antagonist acting on the sodium potassium exchanger. So adverse drug reactions of diuretics are low blood pressure, electrolyte loss. Contraindications would be hypotension or low volume. And then precautions, we need to be careful if we have patients with electrolyte abnormalities when giving these diuretics. And then this is a very, very good picture that I saw. It's from the board review series of pharmacology. So for this table, I think as a nephrologist, this is really what you need to survive. It would show the action of the different diuretics in the different parts of the tubule. So again, I'd like to focus for the proximal convoluted tubule, we just have the osmosis. For the thick ascending limb, we have the NAK2Cl cotransporter. For the distal convoluted tubule, we have this is the thick ascending. And then for the distal convoluted tubule, we have the sodium chloride cotransporter. And then for the cortical collecting duct, we have the angiotensin receptor as the mode of action. So these are the ones that are blocked by our diuretics. So thank you very much for your kind attention. And if you have any questions, you can just type them in or you can have your liaison officer communicate with me. Thank you very much and have a good day.